Good afternoon, everyone. My name is Joseph Garbley. I'm here with my esteemed colleague, Dr. Dean Drosnes. I am the Chief Medical Officer and Executive Vice President at Caron Treatment Centers. I'm also on the board of the American Society of Addiction Medicine, and I am the chair of the Physician in Training Committee for the American Society of Addiction Medicine, and Dr. Drosnes is part of that committee. And the task of that committee is to really bring education into the forefront in medical schools, in primary care residencies, and also to standardize addiction medicine fellowship training. We're lucky enough to have an addiction medicine fellowship at Caron. We're one of the few in the country. There's only 45 currently in the country. We were one of the first, and we recently got our ACGME accreditation. Addiction medicine has really grown in leaps and bounds in the last few years. It's a fully codified subspecialty in medicine, and it is an important part of medical education. And this is part of what we do, is to try and reach out and try to dispel some myths, some misconceptions, and to really educate folks on what is addiction, and in particular, in this case, what is opioid addiction. So the basics about opioid addiction. A few years ago, the DSM-5 came out and changed how we talk about addiction in general. So instead of calling it a dependence or abuse, we now understand each substance to be a use disorder. And those use disorders can be mild, they can be moderate, or they could be severe. And it's important to understand when you talk about opioid use disorder that prescription opioids can be problematic, and the misuse of prescription opioids is its own separate category. And when I say misuse, it's using opioids more than is prescribed in a greater frequency, or changing the delivery of prescription opioids so that you get the maximal effect. We also want to talk about harmful and hazardous use when we talk about substance use disorders, because that's when we can really do the best work. If we can identify the problem upstream, we can intervene successfully and perhaps not allow someone to go down a path of a fully codified substance use disorder. We have a large group at Caron that is dedicated to identifying harmful and hazardous use patterns in school systems. That's our student assistance program. We're in about 1,000 schools up and down the East Coast, and their job is to really try to identify things early, intervene, and perhaps turn the ship around so these young people don't go on to need our services at Caron and don't go on to have a fully codified substance use disorder. So the American Society of Addiction Medicine spent a lot of time around defining what addiction is. And it's really important for you to understand that addiction is a chronic brain disease. So I'll read you the definition, and we'll go through it as we go through this talk. So addiction is a stress-induced, genetically mediated, primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. And this is reflected in an individual pathologically pursuing reward and/or relief by substance use and other behaviors. So this definition really engenders what the chronic brain disease that addiction is. And it's really important to understand the risk factors that can lead to addiction, and also the brain areas that are affected by this chronic brain disease. So let's talk for a second about a disease. For so long, addiction has been looked at as a moral failing or a lack of willpower. It is neither. We have studied it upside down and sideways, and there is no question that there are definitive changes within the brain that fully codify it as a disease. And a disease is defined as a defect in an organ system that produces a characteristic pattern of signs and symptoms. And you see that in many different diseases that we fully accept as diseases, like diabetes, lung disease, heart disease, obesity, All of these, we would never debate whether this is a disease or not. We would never call them moral failings or never say it's a lack of willpower. These are chronic diseases that we fully accept, and we need to fully accept addiction as a chronic brain disease. The problem with addiction is that it's an evil disease. It doesn't look like a disease. So a lot of people are engrossed in self-deception, which is denial. So they're saying to themselves, I don't have this disease, that only if I drink after 5 o'clock, I won't be affected by alcohol, or I won't have this disease. If I change from drinking from the right hand to the left hand and I'm right-handed, that's another way to modify this disease, without really understanding that they can't stop, that they actually have lost control, and that all things that they try to do are not going to work. It affects genetically susceptible, vulnerable people, and has a highly variable course. Some people spontaneously remit, just like other chronic diseases. Some have very poor prognoses, especially those who are untreated, and some will chronically relapse despite excellent treatment. Culturally and politically divisive, I've talked about that for too long. We've looked at this as a moral failing and a lack of willpower, and this is really a societal challenge for us, because that stereotype is still ever present, and we still want to call this a moral failing, a loss of willpower, and not look at this as a disease. So let's talk about the different areas of the brain that are affected by this chronic brain disease. So the two main areas of the brain that are affected are categorized as the motivation system and the choice system. So in the motivation system, it's really the reward system. This is a dopamine-rich area. It extends from the ventral tegmental area to the ventral striatum, or the nucleus accumbens. And what you see there is increases in dopamine that occur when someone uses their drug of choice. And depending on the drug of choice, the dopamine levels will increase higher or lower. Just to give you some ideas, built into this area are natural rewards. So when we eat when we're hungry and drink when we're thirsty, dopamine rises in these areas that I'm talking about, the motivation area of the brain. And when that happens, that tells us we need to continue to be engaged in survival behaviors. But eating when you're hungry will only increase dopamine about 1.5 times the baseline. If you take a drug like methamphetamine, that increases dopamine in that same area 11 times baseline. Opioids are around 7 to 8 times baseline. So you can see that if someone's engaged in their drug of choice, it's very difficult for them not to get a euphorogenic pleasure from the use of the substance, and it rewards them to continue to use on a regular basis, to the point where they stop being engaged in survival behaviors. They stop forming relationships. They stop having intimate relationships. They stop eating and drinking like they should, because the drug is enslaving them, because the dopamine levels are so high and give them such a euphorogenesis that they just keep reaching for the drug. There's been studies that have been done by the NIH looking at rodent models, and what they've seen in these rodent models, for instance with cocaine, that a rat will hit the lever for cocaine and not hit the lever for a mate, not hit the lever for food, and not hit the lever for drink, and they die. They just continue to hit the lever for cocaine. And we see that translate into human behavior when folks do end up coming to Cairn for residential treatment. The choice mechanism is very important in the paradigm that we understand as a chronic brain disease. When we're talking about choice, we're talking about the prefrontal cortex. That's an area of the brain that matures late. We used to think that the prefrontal cortex was fully mature and the brain itself was fully mature by the age of 16. We now know that for women that the prefrontal cortex and the rest of the brain is mature at the age of 23. For men, most women would say never, but actually it's age 26 that the brain is fully mature. And that last piece, the prefrontal cortex, is last to fully mature. And the prefrontal cortex is where we engage in sound reasoning, good judgment. It's what we call the brakes and steering of the brain. It allows us to stay within the confines, the mores and rules of our society. And when someone is engaged in active addiction, that area is not active. It's hypoactive. So the area of the brain that just gives you the euphorogenesis, that motivation area, that's hyperactive, overly active. And then the area where choice is concerned is hypoactive or not active at all. We've actually done studies at Cairn in concert with Penn State University School of Medicine and now with Stanford, looking at the predictive value of this particular area of the brain, imaging it deep into treatment, meaning weeks into treatment, and seeing if there is any predictive value around that activity in the prefrontal cortex. And what we found is that if the prefrontal cortex remains hypoactive late into treatment, that portends relapse. And we were able to predict relapse 85% of the time in both alcohol use disorder and opioid use disorder in our Penn State study. The Stanford study has just begun, so I can't comment on that, but we feel strongly that that'll have a similar predictive value. So that area of the brain, if it doesn't come back online, really can portend relapse. I'm going to turn it over to Dr. Drosnes, and then I'll be back.
Thank you so much. So I'm Dean Drosnes, and I have the pleasure of doing the easy part now, which is to talk to you about what does this look like. Dr. Garbely gave an overview of the science, and that's extremely important in our understanding of addiction as a disease. But I think for many people, what they really want to know is, well, what does addiction look like? And opioid addiction is not confined to somebody who is kind of a wretched character injecting themselves with a needle. Addiction can have many faces. So what I want to do is kind of marry the diagnostic criteria with what an individual may see when they are looking at somebody who has opioid addiction. So the signs and symptoms, as we talked about before, this is what makes a disease, the signs and symptoms, are broken down into 4 categories. And those categories are loss of control, social impairment, risk-taking, and drug-specific problems around the opioids in this case. So I want to talk about loss of control and social impairment. So the first element we like to look at is taking larger amounts of the drug over a longer period of time than intended. Now, just as an aside, my clinical focus is on people who have chronic pain. And so opioid prescribing for chronic pain management has been a staple in American medical practice. So with a lot of what I'm going to say, think about somebody who's taking opioid prescriptions for pain control. So what does this look like? Well, for many people, it looks like just getting multiple prescriptions refilled for a potentially longer time than they really need the medications to effectively manage the pain. In other words, a person has a wisdom tooth removed or may have an endoscopic appendectomy. And those procedures, certainly we would expect that somebody within about a week's period of time would be at a point where they no longer require opioid medication, but they may be getting the prescription filled over and over and over again. And that's taking over a longer period of time than intended. Higher doses is oftentimes seen, so people can develop a tolerance. That's another criteria, but in addition, there's an effect, as Dr. Garbely alluded to, this euphoria that is a side effect of opioids that some people like more than others and want to get more of that, and so will increase the dose without being sanctioned, excuse me. Doctor shopping, getting prescriptions from multiple providers in an effort to stockpile opioids or take higher doses. And then supplementing prescription opioids with illicit opioids. And I guess perhaps not only illicit opioids, but it's not unusual for a person who is taking prescription opioids to come to the conclusion that they really need more and to ask their relatives or friends or neighbors if they have any pain medication that they can take. In addition, unfortunately, in this day and age, we are seeing people who are getting prescription opioids also supplementing with illicit opioids in the form of heroin and nowadays fentanyl. So these are signs of this criteria. The second criteria I want to talk about is a persistent desire or an unsuccessful effort to cut down or control opioid use. So we hear very frequently from people who say, you know, I want to stop, but I can't. When I try to cut the dose down or when I try to stop this medicine altogether, I actually feel worse. The pain comes back, and the pain may be worse than it was when it started, so I have to continue to keep using the medication. And so people try to cut down, but they can't do it. A rigid adherence to a dosing schedule to make their medication last. So what many people who are becoming dependent on a medication find, or an opioid medication find, is that if they run out of their prescription before it's time to get the new one refilled, they go through withdrawal, and they're very, very uncomfortable. And so they try to make the medication last, and they may have withdrawal symptoms in between doses. So they may, instead of taking one tablet every 4 hours for pain, they may take a half every 2 hours. In other words, they're changing the way they're taking the medication in an effort to control the medication supply and the medication effect. And that's, again, another sign of loss of control. They may stop their opioids at a reasonable time after some a surgical procedure or an injury, perhaps, but then restart opioids because the pain has come back or because I had a repeat injury, or they may recognize that I very much liked the way I felt when I took these opioids after I broke my arm, and now I'm having some neck surgery, and even though it's minor, I'm going to need to have these opioids, right? These are signs that the brain is developing a taste, if you will, for use of opioids. Craving, or a strong desire to use opioids. And craving is a word that can be taken many different ways. And, you know, sometimes we think oftentimes of a physical craving where somebody, you know, as we were talking about chocolate earlier, and sometimes you have a chocolate craving and it's just like, oh my gosh, I won't be satisfied until I get that delicious piece of dark chocolate in my mouth. You know, it's this physical sensation. And that's not always the case with opioid medication. Opioid craving may just be a preoccupation with thinking about it, right? Geez, when I was taking those medications, I felt much better, and I don't feel good now. People frequently will take their medication and it'll just be taking effect, and they'll be thinking about the next dose already. Okay, I've taken it, it's 8 o'clock now. I have to wait till noon to get my next dose, and that's a very concerning symptom. Saying, I really don't feel even my normal self without the drug. That's very significant sign that people are becoming addicted to the drug. And then cravings during withdrawal, when the effects of the drug after several weeks of consecutive weeks of use, cravings are particularly high, and it's a very uncomfortable feeling. Spending a great deal of time obtaining or using the opioid or recovering from its effects. Now, this sign with somebody who's using illicit drugs is much more prominent because, you know, they may have to go to a dealer to obtain their illicit drugs. By prescription, it's not as prominent because they have a supply and they may very easily get their supply renewed. But what you may see, especially in the relationships, is you may see people who start to isolate at home, who start to take breaks from work, who come in late or leave early. Why? Because they're spending time trying to make arrangements to renew their supply of their medications. Social impairment is really important. This is where family members, friends, coworkers can oftentimes recognize some aberrant behavior that's associated with addiction. So absenteeism is pretty obvious. People are either under the influence of an opioid or maybe they're in withdrawal from an opioid and don't show up at work. Presenteeism is also very common, which is I like to say presenteeism is when somebody is physically present and psychologically absent. So this often happens when there is a close person, a family member, a significant other with a substance use problem, and the worker is preoccupied with the well-being or lack thereof of the person with the opioid disorder. And so they may be coming to work, but they may not be there. And that's oftentimes very obvious to coworkers. Tardiness, again, as I mentioned previously, missed appointments, missed deadlines to complete assignments, just a deterioration in productivity, whether that's amount of productivity or whether that's timeliness of getting the work done. Not meeting financial obligations. People start to get into debt or not paying their bills because they're saving their money to purchase opioids illicitly, and missed appointments for the same reason. So these are social obligations that may occur in the family or in the workplace. And similarly, having impaired social relationships or interpersonal problems. So frequently, people with opioid use disorder will have deterioration in their primary relationships, so divorce and separation are common. They may have parenting problems with their children. They may have parenting problems with their parents, depending on where they fit in the family tree. Their coworker relationships are oftentimes strained. They may have legal issues. They may have altercations that may occur at work or in any social environment. And they may show up at social events impaired. Dr. Geiberle and I were just sharing a story before we started about an individual who had been in recovery from a substance use disorder and then relapsed at a very inappropriate time at a wedding reception and caused a lot of havoc. And we all know people who have done that. Oh, maybe we don't all know, but many of us do. But the point is, in opioid use disorder, people continue to use opioids and they may very well be very impairing. Giving up or reducing activities that people previously engaged in as a result of their substance use. So they may stop playing sports, they may stop playing music or other recreational activities that they used to enjoy as hobbies. They may find themselves homebound, or you may notice that they're just not going out, and they may become very sedentary. The couch potato lifestyle is frequently seen in people who are developing an opioid use disorder. All right, let's hand it back to Dr. Geiberle.
Thanks, Dean. So the next set of symptoms that define opioid use disorder have to do with risk-taking behavior. So using opioids in physically hazardous situations. So using opioids to the point of impairment while you're driving. So this is the drug driving. So, and even if you have a prescription and you're involved in a motor vehicle accident, you very well may get charged with drug driving because of the fact that you are operating heavy machinery and there's a warning not to do so. Using during work. So if you're prescribed prescription opioids and they're set for every 4 to 6 hours to take if you have pain, if you do take it at work, it's possible that may impair your productivity. We see this with healthcare professionals. We see these with airline pilots. They have legitimate prescriptions, but they have safety-sensitive professions, and that using these impairing substances can put people at risk. So we have a healthcare professionals unit, and oftentimes we see physicians, nurses, and other healthcare professionals who were prescribed opioids, took them as prescribed, but it impaired their ability to make good judgments and also to perform the tasks at hand. And as a result, they were asked to be sent to treatment and come off the opioids. Also, using opioids while caring for children can be very dangerous because you can lose track of time. Opioids can be very sedating, and if they are, it's possible that the children are unsupervised. And then, of course, combining with other substances like benzodiazepines, that's very common with opioids. There's a synergistic effect when you use benzodiazepines. Xanax is an example, Valium is another example. With opioids, there's an increased euphoria that occurs when you take both together, but there's also an increase in sedation and impairment when you use both together. Alcohol also will increase the sedation of an opioid and can significantly impair someone who is prescribed prescription opioids. Other risk-taking behaviors can lead to repeated injuries. Opioids are pain relievers, so you may not feel the pain that others will feel while you're taking opioids on a regular basis. That may put you at risk. You may actually put yourself in a position to get burnt or to injure yourself and not really feel it and not do anything about it until the pain starts to really act up. And those injuries can be quite significant. Significant weight changes. What we see oftentimes is the lack of the survival behaviors, as I mentioned before. So opioids become the lever that's hit instead of eating when you're hungry and drinking when you're thirsty. And we often see emaciation or a dramatic decrease in weight. Infectious diseases happens when you convert from oral opioids or intranasal opioids to intravenous opioids. So we see a tremendous amount of cellulitis that occurs from injectables. We also see abscesses secondary to injectables. Memory lapses, forgetfulness, opioids will affect the hippocampus, diencephalon, mammillary bodies. These are all areas of the brain that are important with storage and encoding of memory. And so that impairment will cause someone to operate in ostensibly a blackout and be very forgetful. Irritability and mood swings are very common. This is that interdose withdrawal. So they could start to feel this irritability, their mood will swing as a result of the fact that they are in mini withdrawal between doses. Depression and anxiety are ubiquitous when it comes to opioids. Opioids act as a depressant, and they also will reduce anxiety when you're using them, but in between doses, you can start to see anxiety pop up. And tolerance. So tolerance is something that's ubiquitous. So if you are prescribed chronic opioids, you will become physically tolerant to those opioids. Everybody does. So you'll need more and more and more of the opioid for the desired effect. If the desired effect is pain relief, you're going to need more opioids over time to get that pain relief. If the desired effect is euphorogenesis, or getting this sense of well-being with increased energy, that's what euphoria is, then you're going to need more and more and more over time to get to the desired effect. The problem is that there is a disconnect. So the euphorogenesis tolerance and the pain relief tolerance is different than the respiratory center tolerance. And that's where you see overdoses. So when we see patients who survive overdose, the typical story is that they needed more and more of their drug of choice to get the good feeling, that euphoric feeling. The problem is they cross a threshold before they get to that euphoria, and they go into respiratory failure. Opioids act on the central respiratory system, and that tolerance lags behind. The tolerance for euphorogenesis is first to happen. So you could be using more and more and end up inadvertently overdosing and never feeling the euphoria that you seek. Hyperalgesia and allodynia are important concepts and sort of counterintuitive. These are pain relievers that cause pain. So if you're on chronic opioids for pain relief, eventually the actual medication will cause your pain to get worse. That's hyperalgesia. It'll also cause a phenomenon where non-painful stimulus can cause pain. So, for instance, combing your hair, that's odd coming from me, but for those that have hair, combing your hair can start to cause pain, and that's because of the medication. The medicine actually causes non-painful stimuli to create pain. So drug-related problems that people experience with the use of opioids, withdrawal is absolutely ubiquitous throughout the paradigm when you're talking about an opioid use disorder. Even when you have a set schedule for your opioids, because of physical tolerance, you will have interdose withdrawal over time. And withdrawal looks like anxiety, sleeplessness, nausea, vomiting, diarrhea, excessive sweating, chills, tremors, restlessness, joint pain, muscle pain. What we see when we look for withdrawal is dilated pupils. That's myadriasis in our terminology. So dilated pupils are a sign that we see that show the withdrawal from opioids, and increased lacrimation and rhinorrhea, or runny nose. So the terms kicking the habit, that comes from a restless leg syndrome that comes with withdrawal. So that's when people are going cold turkey. That also is a terminology for coming off of opioids. And what that refers to is something called piloerection, or goosebumps that you get. Another sign that we can see that someone's in withdrawal. And kicking the habit is when they are in the throes of withdrawal and they can't stop their legs from moving. So that's where that terminology comes from. So we talk about the myths and misconceptions. So one of the myths around opioid addiction is it is just a psychological disorder, and people who are dependent simply need better willpower. Well, I think we've addressed that. This is not a lack of willpower. It's not a moral failing. Opioid addiction is a disease. It's biological, psychological, social, and spiritual, as the definition from ASAM tells you. Lack of willpower, moral failing are obsolete, and we need to move beyond that paradigm. For too long, we have blamed the addict. If they relapse, it's their fault. You know, if they come into an emergency room and they are suffering with addiction, they're the last to be seen. They're punished for their disease. We have to stop doing that. We wouldn't do that with a diabetic. We would not do that with someone with chronic lung disease or cancer or HIV. We can't do that with the chronic brain disease that is addiction. And addiction is the result of progressive brain changes over time. That is not up for debate. That is proven. That is science. Just like we understand cancer in a scientific way, diabetes in a scientific way, we understand addiction in a scientific way. It is a change in the brain. It's a chronic brain disease. So this is a busy slide that looks at the interplay of addiction. So the green is that preoccupation, that anticipation that Dr. Drosnin has talked about, that craving. Many medications target that green area. And those medications are called medication-assisted treatment. So methadone maintenance, buprenorphine maintenance, and Vivitrol, and Sublocade now, and Probufene, all of these medications target craving. They reduce craving, which is incredibly intense in an opioid addict. The worst craving that I've ever seen is an opioid use disorder. So we have to reduce the craving so that they can settle down and begin the process of getting better and getting treatment. So medications are targeting that green area, that preoccupation, that anticipation that we call craving. Then the blue area is what happens when someone, this is the areas that light up when you're in the act of using. So binge using, the act of intoxication, and the red areas are the areas that light up when you are withdrawing. So this is the science behind the chronic brain disease that is addiction. It's all been worked out. There is no debate that this is a chronic brain disease, and these are the areas that are activated in different phases of addiction. So another myth is people with opioid addictions have a specific appearance and are easily recognizable. That is wholly untrue. If you come to our campus, you will see executives. You will see healthcare professionals. You will see college students that are actually doing well in school but are addicted to opioids, whether they are prescription opioids or illicit opioids. There is a point in time where people can function and look normal, quote unquote normal, before something happens that brings them into treatment. So the stereotype that we've gotten used to is from injectable heroin. And the stereotype is of an emaciated, unkempt person with visible injection marks. Limbs represent a case of late-stage addiction to opioids. Those in the earlier stages often appear completely normal, and that's what we see. Behavioral patterns are far more reliable than appearances for recognizing opioid addiction. So when you see that anxiety, those mood shifts, you have to start thinking, what's going on here? Could they be between doses? Could they be withdrawing? Are they on something? We have to ask questions. We can't just accept these changes in personality as part of the normal paradigm, because they're probably not. Opioid addiction is an equal opportunity destroyer, and we see it every day on our campus. This is just a look at those that have opioid addiction. This is from the internet, so this is not a HIPAA violation, not a 42 CFR Part 2 violation. This is all from the internet. And what we need is more faces of addiction. Magic Johnson changed how we look at HIV. And we need a Magic Johnson. We need a Magic Johnson to step out and say, hey, I suffer from addiction. I'm recovering from addiction. It's a chronic brain disease. Please accept it as such. And some of these celebrities have been quite open, others very secretive. What we've seen at Caron in the last couple years is that when someone does die of an overdose, that the family does talk about the fact that they died of an overdose. They actually say it in the obituary. So that's beginning to change. And until we take addiction from the darkness into the light, we are going to continue to say that it's a moral failing and it's a lack of willpower, and it is neither. So another myth is prescription opioids aren't all that addictive. We as physicians, ushered in this newest addiction, opioid use disorder epidemic, I should say. Oops. And, we were told by pharmaceutical companies that medications weren't addictive and that we need to really address pain on everyone, and we need to prescribe medicines if they have pain. But we were complicit in that. We own that. We have to change that. We are now at a 10-year low of opioid prescriptions. There's 66.9 prescriptions per 100 people in this country. It used to be well over 100 prescriptions per 100 population. So we're getting better, but we have a long, long, long way to go. 77% of heroin users have used prescription opioids prior to using heroin. So we introduced them to opioids, and then they moved on to heroin. Numerous attempts to make prescription opioids tamper-proof just haven't worked. There's always a way. Street pharmacists figure it out. OxyContin was a medication that pharmaceutical reps came into my internal medicine practice and said, this is not addictive. This is the pain reliever you should be prescribing because it isn't addictive. Well, we all know how that ended. That was Purdue Frederick and their pharmaceutical reps. So remember, addiction involves the drug, the person, and the environment. It's very important to understand that. And this last slide before I turn it over to Dr. Drosnis is from 1980. So this is a retrospective chart review from Boston University Medical Center. And what they looked at is hospitalized patients who received narcotics legitimately for pain, and who, in that very short time that they were in the hospital, became addicted. And they found out that tens of thousands received opioids, and they said only 4 became addicted. So this study, and I'm using air quotes here because it's not a study, it's a retrospective chart review. And it's a confined time within the hospital. We're talking days within a hospital, and it takes more than days for someone to become addicted. But what happened after this study came out was, and it came out in the New England Journal of Medicine, drug companies grabbed it and ran with it. And what they said is our medications are not addictive. And they sold it as such, and they sold it to us as such. And there is no science in what they did at Boston University Medical Center. They just looked at charts, and they had a faulty preposition and hypothesis. It just should never have been run with, but it was. And it really ushered in this whole idea that pain is the 5th vital sign, that we have to check everyone for pain, and if they have pain, they have to be treated with medications, and if you don't treat them adequately, you won't get paid as much from the Centers for Medicare and Medicaid services. So all of that conspired to this prescription opioid epidemic, which has led to a heroin epidemic and now has led to a synthetic opioid epidemic in the form of fentanyl, its congeners, and precursors. I'll turn it over to.
Thank you. All right, want to be mindful of time here. So another popular misconception is patients with pain don't get high on their opioids because they're not taking it recreationally. And I remember hearing this actually in my medical training, that people who are legitimately in pain can't get addicted because the pain will prevent them from getting addicted. And that is absolutely not a true statement. So when people are in pain and they're taking a prescription opioid, the pain is definitely anti-euphoria, right? You know, when you're having pain, that's not part of the euphoric experience that you're looking for. However, it does not preclude people from developing the brain disease that addiction is. So it does not follow. It's a non sequitur, and it's a common misconception. Most people with chronic physical pain, and this is crucially important, this is the work that I focus on, have not only physical pain, but they have social pain, and they have emotional pain as well. And that's part of the overall pain experience. And one of the properties of opioids is it seems to help all of those dimensions of pain. When we look at the brain in pain, there are certain areas of the brain, and I won't get into great detail with this, but there are certain areas of the brain that light up, that are more active in a state of pain, and this has been shown in multiple centers across the country in these images. But it doesn't matter whether the person is in physical pain or emotional pain, or if they're in social pain. In other words, they're being ostracized or they're isolated from loved ones in a support system. The same areas of the brain are activated, and these areas are targets of opioid pain medication. So as was previously mentioned, analgesia, taking away of pain, is a property of opioids. That's what we're looking for. Euphoria is another property of opioids. That's what some people are looking for. So there's active efforts being undertaken right now at the level of the National Institutes of Drug Abuse, National Institutes of Health, to look for opioids that have the analgesic property without the euphorogenic property. And there's a lot of anticipation of what that's going to look like. So just to remind people that these drugs have more than what we're looking for. Another myth, opioids are the most effective drugs for chronic pain. Well, in the program that I administer, because of our patient population having substance use disorders, they're not an option because of the way they affect the brain. And what we have found is that, number one, there are no scientific studies that show that opioids are any better than other medications, especially for chronic pain. So there just simply is no scientific literature to back up that claim. Number two, that comprehensive pain treatment using multiple modalities, what I call movement modalities, getting the body in motion, using topical agents, non-narcotic medications, massage therapy, acupuncture, chiropractic, tai chi, qigong, there's tons and tons of therapies that are very helpful for chronic pain, and these are actually much more effective than opioids for long-term benefit. So in our center, what we do is we have a team of pain treatment professionals who gather around, as in the picture on the far right, gather around the patient in the center there, rather than on the left, what you see if you're a patient in the outside world and you have to go to see 5 different people on a regular basis to get pain relief. So what we do is we introduce people to multimodality pain treatment, take them off of opioids, and then they get to select what they're going to follow up with after they leave. And what we find is essentially everybody gets better pain relief off of opioids in the long run. And I'm turning it back to you at this point.
So another myth, the majority of opioid drugs are obtained from illicit sources. That's not true. The National Survey on Drug Use and Health actually showed that most folks get it from friends and relatives. And this is just a pie chart showing exactly that. The commercials that you see of somebody looking into their medicine cabinet of an older age, and then medicine cabinet opening, and then when it closes, after the pill bottle is taken out, there's a young kid there. That's a reality we hear every day. So folks are prescribed too many opioids for a month, for instance. They only need a few days, but they keep them. They keep them in their medicine cabinet, and then their grandchild or their son or their daughter will go in and get it. Another myth is medication-assisted treatment is just one drug replacing another. That is wholly untrue. The studies that have been done on methadone maintenance, the studies that have been done on buprenorphine maintenance, and on Vivitrol, which is an antagonist, Sublocade, Probufene, these are all medication-assisted treatment strategies, are very sound. They've held up to scientific rigor. And they clearly reduce cravings, they reduce relapse risk, and they reduce the risk of overdose. And we have to start using them more often instead of somehow vilifying them as another drug replacing the drug of choice. So chronic disease, addiction is a chronic brain disease, which I've said many times, and chronic diseases are treated, not cured. They're characterized by relapse and remission. That's exactly the same for addiction as it is any other chronic disease. Outcomes depend on continuity of care over time. We have a model in which we follow our patients for a year after treatment and give them recovery supports and make sure that they stay in treatment for at least a year and even longer if possible. Pilots, airline pilots and physicians have to stay in treatment for 5 years. The reason why these markers, these time markers are important is after 1 year, your risk for recovery is greater than your risk for relapse at 1 year. And at 5 years, your risk of having an addiction is no different than the general population. Even though you had greater risk factors, at 5 years, you're back to the risk of the general population. And then, of course, genetic plus environmental factors determine vulnerability. And this is just looking at different chronic diseases side by side, and you can see drug addiction's relapse rates are no different than other chronic diseases. The one caveat I'll say is that opioid addiction is particularly difficult to treat. It's because we underuse MAT strategies, for one, but relapse rates can be very high, greater than 70%. If you just give detox for opioid use disorder, 91% will relapse, just detox. If that's all you give, 91% will relapse. And this is just looking how we approach treatment at Kieran. If you look at the limbic area, we use medications there. That's the MAT strategies that I've mentioned over and over and over again. The cortex area is where we do counseling. It's where we start to address other co-occurring mental health issues, addiction interaction disorders like sexual compulsivity, pathological gambling, pathological shopping, things of that sort. So those things need to be addressed in concert with the addiction itself. But the medications have to calm the limbic area of the brain. That reward center I talked about earlier that craving has to be calmed so that they can participate effectively in treatment. Another myth is that you have to hit rock bottom before you decide to get help. The truth is that court-ordered treatment works. So mandated treatment works. interventions work. So before the person's ready, getting them into treatment works. This is just a study looking at mandated treatment versus non-mandated treatment, and you can see mandated treatment works as well, if not better, than non-mandated treatment. Another myth is detoxing on your own is enough. I mentioned to you the relapse rate after just detox. It's 91% in opioids, so that is not sufficient. So if treatment is just that, then they have really only a 9% chance of succeeding after that. And there's many different strategies out there that are homegrown to try to stem the withdrawal and treat opioid addiction that do not work, kratom, cannabis, and other nutraceuticals. This is the slide that I mentioned about detox. And then this is a slide looking at the do-it-yourself withdrawal ads. If you Google withdrawal management of opioid withdrawal on the internet, you'll see a whole host of different strategies. They do not work. They have not been studied. They do not work. We have medications that have been tried and true, that have been studied, that need to be utilized, and they are underutilized. We need to start utilizing them sufficiently. Another myth is opioids are bad and everyone who takes opioids will become addicted. That's not true either. Some people do need opioids, especially for acute pain. They should get it. Doesn't mean they're going to become addicted. We just have to monitor the effects of it. One thing that I teach medical students and residents is that if someone tells you, I can't take this at night because I get too energetic and I can't sleep, that may be a sign that they may have a proclivity towards addiction. We're about to undergo a huge study looking at genetics that predispose folks to opioid addiction. That's a study that's is funded by the NIH, and we're going to be a group of, we're going to be using our opioid treatment program as the group for control. And then we're going to be comparing it for those that shouldn't have a high risk and looking at the genetics behind all of that. And this is just the CDC guidelines. I won't go through that, but thankfully we have them and we're asked to follow them. And we're asked to get education every 2 years on responsible opioid prescribing. So we're starting to get a handle on this problem as physicians. So real quickly at the end, conclusions: opioid addiction is a chronic disease and can be successfully treated. Signs and symptoms of opioid addiction may be obvious or may be subtle. We can't be looking for a specific person having a view of what an opioid addict looks like and missing someone who's right in front of our eyes. People with opioid addiction require treatment, not judgment. And many misconceptions about opioids and those addicted to them are promulgated in the media. So that has to end. We have to start talking about this responsibly. So that's our talk. Thank you so much for inviting us. It's been an honor and a privilege to be here. Any questions, please don't hesitate to ask.
Yes, there's one question. So someone asked, is it true that there is a treatment now that is once a month injection rather than a daily dose of some medication that the person has to go get at a clinic every day?
Yeah, so the question is there a once-a-month treatment for opioid use disorder? The answer is yes, there is. It's called Sublocade. That is buprenorphine, which is a partial agonist, and it reduces cravings, reduces relapse risk and overdose risk, and it is given in a clinic. And it is a shot once a day. There's also once a month. It's given once a month. And there's also pellets that can be inserted that last for 6 months. That's called probufene. Same medicine, buprenorphine, has to be done in a clinic. So it's not something that you have to take every day.
Okay, and also since opioid addiction is chronic, does someone addicted to opioids have to stay on treatment for life, medication therapy for life?
Okay, the question is, since it's a chronic disease, should they stay on medication for life? That is being worked out in studies. So unfortunately, we don't have the answer, but we keep folks on medication-assisted treatment at least for a year. And if they're doing well, we continue that treatment. There's no reason to stop it if they're doing well. So the studies are being done as we speak. We'll soon understand whether we need to keep them on medication for life. If you think about it, look at it like a diabetic. Sometimes they need insulin until they lose some weight, they start to exercise more, and then maybe they go to medications instead of insulin over time. So a similar idea for a chronic disease paradigm of treatment. Thank you again.